time, its clinical pictures is similar to trichotillomania or TTM. Thus, it leads to incorrect diagnosis and management. I would like to provide major differential diagnosis signs for these related forms of alopecia and describe in details trichoscopic features of alopecia areata and trichotillomania. Alopecia areata is an organ-restricted T-cells mediated autoimmune disease of hair follicle. Disease in dogs is associated with collapse of hair follicle immune privilege in both human and animal models. In this illustration, we can see that cytokines and cellular factors responsible for maintained immune privilege are listed in the left box. These factors believed to mediate loss of immune privilege and initiation of disease are listed in the middle box. Loss of immune privilege is associated with expression of MHC class I molecules, which are capable of presenting hair follicle autoantigen to T lymphocytes. Secondary autoimmune amplification circuit that may help establish or amplify the pathology listed in the right box. There you can see histological feature in alopecia areata. We can see perifollicular infiltrate of lymphocytes like swarm of bees. Alopecia areata often results in very significant psychological distress, as the condition often affects children and teenagers and can cause sudden and widespread scalp hair loss, like alopecia totalis, or complete body hair loss, alopecia areata universalis, with resulting negative effect on the quality of life, psychosocial parameters, and psychoemotional symptoms. The most common presentation of alopecia areata is isolated round areas of complete hair loss without clinical signs of skin inflammation, characteristic short hairs taped towards their base, inflammation point hairs, as well as regrowing white hairs may be present, allowing for rapid clinical diagnosis. The nail matrix may also be affected, resulting in pits in the nail plate or even more severe nail dystrophy. While the scalp is the most frequently affected site, according in 90% of cases, the disease can progress with loss of facial, eyebrow, and eyelash hair. In alopecia areata, the alopecia fossa is hairless, but important feature typical of acute alopecia areata are present around the edge of the fossa. Pulpincus constriction refers to periodic constriction in unagain hair follicles that are seen in patients with alopecia areata. They are also called monolatrix-like constriction, as well because their hairs resemble the hair seen in the genetic condition monolatrix. The constricted areas occur because the hair follicle matrix, which produces the hair follicle, enters into a period of reduced keratin synthesis on account of the abundant inflammation present in the scalp. Constriction scenes in the follicle remind us that the inflammatory activity was high during that particular period of time. Constricted areas, and notably weaker and hair breakage, often occurs in the areas. The areas within the pulpincus constriction might also be lighter in color because of reduced melanin transfer into hair follicles as well. Unlike the total and trichotillomania on TTM universalis form of alopecia areata, which are not included in the differential diagnosis. Local and subtotal forms of alopecia areata display similar patterns to TTM. Localization, scalp, eyebrows, eyelashes, clinique, complete or partial absence of hair growth in the face, trichoscopic things in the alopecia areata, like black spots, pinnate hair, tulip-shaped hair. During the process of careful examination, it's available to suspect some evident features of TTM when the focal on the head looks irregular in contour. They are located in scalp areas that are easy for hand assess, and also we can observe short pigmented hair in the foci. Trichotillomania is very similar in appearance to alopecia areata, but has a completely different nature. Trichotillomania, also called hair pulling disorders. It is classified on obsessive compulsive disorders in the 5th edition of Diagnostic and Statistical Manual of Mental Disorders. The scalp is the most frequently affected place. However, the eyebrows, eyelashes, and pubic hair may be also be involved. TTM is 7 times more common in children with 2 peaks of initiation, 0–5 years and between 10 and 13 years. In this latter group, patients commonly report feelings of anxiety and distress that are only relieved by the act of pulling the hair. Clinical features in trichotillomania: irregular patchy alopecia, hair of different lengths and excoriation. Hair pulling test is negative. When localized to eyelashes, it only involves upper eyelashes. Within trichotillomania, applying force along the length of this hair results in pulling hair out. The stems are torn, forming broken hair and varying lengths. The characteristic change of broken hairs ends are most commonly split and twisted hair, V-shaped hair tucks in flame-tongued shaped ends. Trichoscopic things in trichotillomania include irregulatory broken hairs, wave things, flame hairs, collid hairs, tulip hairs. In this picture, we can see trichoscopic things specific for trichotillomania, like black arrows, microscopic exclamation mark, fine amorphous hair remains almost indistinct from the black dots, and tulip hairs in trichotillomania. However, despite the undoubted other usefulness of detecting this trichoscopic scene, it should be considered that they are not pathognomic for TTM and rarely, but still occur in alopecia areata and other hair disease. Important, when we observed hair growth by trichotillomania, the hairs are pigmented. But in hair growth after alopecia areata, the hairs are depigmented. The pigmented appears a few weeks after hair regrowth. I hope my short report has been useful. Thanks you very much.